We're very pleased to bring to you today three amazing professionals to discuss an important topic, mental health in our youth. First, I want to welcome Jack Bender, who made the transition from business leader to nonprofit leader of LifeAct in 2014. Along the way, he was also a councilman in his village of South Russell. He is the recipient of the Cleveland Foundation's Encore Cleveland Prize because as he transitioned from a 25-year career in the chemical industry, he wholeheartedly embraced the battle against teen depression and works on focusing our young people to choose life. LifeAct serves more than 25,000 students annually, and we acknowledge that Jack is a proud member of the Leadership Cleveland class of 2019. Dr. John Hertzer is on the staff of university hospitals as well as on faculty at Case Western Reserve University Medical School. He's a psychiatrist and specialist in adolescent and child psychiatry, a career that he has pursued for 24 years. He is concerned with all of the teens that are not identified as having clinical depression and who suffer and struggle with functioning in the challenging environment of childhood and adolescence. Finally, I want to welcome Jennifer Reed. Jennifer is a licensed clinical counselor and art therapist who works in the outpatient department at Highland Springs Hospital. Like Jack, she began her career in the business sector, heard the call to serve, and turned her attention to pursuing a master's degree in art therapy and counseling. We are thrilled to have the three of you with us today and look forward to an enlightening conversation. Jack, I'm going to turn it over to you.
Thanks so much, Mary Ann. And thanks to Cleveland Leadership Center for putting this entire series together. It really is an honor to be part of this great discussion. So Mary Ann, Rachel, and the entire CLC staff, coming from I think best looking class ever of the Cleveland Leadership Center. Thanks so much. Thank you also for joining us, Dr. John Hertzer. I would also like to point out that Dr. Hertzer is the president of our organization, and he has served on our board and as the president for several years, and his guidance and insight and ability to reflect on these issues has just been invaluable. And Jen, thanks so much for joining us from Highland Springs Changes. You'll have a chance to say a little bit about your organization. I'd also like to thank our partners from University Hospitals, Rainbow Babies and Children's, Highland Springs Changes, the Cleveland Metropolitan School District, and Courage to Caregivers. Without these community partners, it would be very difficult for us to achieve our objectives. So thank you so much. As Mary Ann said, I'm Jack Bender. I'm the CEO of LifeAct. At LifeAct, our team of trained instructors presents our in-class, evidence-based depression awareness and suicide prevention program to roughly 30,000 students per year. Obviously, this year is a little bit of an anomaly. Through education and early identification, we assist more than 3,000 students annually to connect with the help and services that they need. The next pandemic is one of mental health, and it's already begun. We need to keep our eye on the ball, which most people would consider to be COVID-19, but we need to see the whole game. There's other things going on right now, and we can't lose sight of those. In order to understand what is going on, we need a little bit of perspective. After accidents, suicide is the leading cause of death for ages 10 to 34. It will take more lives than homicide and the next 7 causes of death combined. Cancer, diabetes, heart disease, liver disease, HIV, flu, add them all together, suicide will take more lives. I want to share just a couple of screens with you, and I apologize, I'm reading off script because if I don't have a script, I'm Irish and it would get really long. Of the 10 leading causes of death in the United States, ages 10 to 34, as you can see, accidents are up 25%, homicides are down, the next 7 causes are down, suicide is up 51.1% in the last 10 years. For children 10 to 14 years old, it is up 177% in the last 10 years. These are really disturbing trends, and this is all pre-pandemic. So this is our starting point, what we're dealing with. In addition to suicide prevention, as we mentioned, there are many other serious health issues that warrant investment. Two that I identified, for instance, breast cancer and AIDS. They certainly take a lot of lives. Suicide actually takes more. But we haven't matched up our investment into the problems accordingly. And the next slide will show a little bit about that. $28 billion in AIDS, $100 million for suicide prevention. Suicide prevention, it's an emerging problem that's getting worse and worse, and we really need to not take our eye off the ball. So I will stop sharing. That's enough of my show and tell. So post-pandemic, what are the impacts? While kids might not be quite as isolated now as they were during quarantine, their schedules and interactions will be very different. Not only will this impact the teens, but their entire family. In-person contact aids in maturity and socialization, while the extracurricular activities, they build self-esteem and confidence, which are protective factors against depression. Pandemic isolation and reduced in-school programming will increase the educational, economic, and workforce gender gaps, especially burdening the minority and urban populations. The CDC and the American Pediatric Society are both strongly recommending a return to school, not just for the educational component. School personnel are frequently the early warning system for kids who are struggling, and schools represent safety, nourishment, structure, and a whole host of other benefits that aren't necessarily just considered education. Several local hospitals have already reported a disturbing decrease in mental health ER visits and great concerns with problems they're having connecting teens via telehealth. We need to remember that mental health is a health issue. We need all the community and healthcare resources we can get. At LifeAct, although our traditional delivery model has been impacted, we're finding new ways to reach out to students, parents, and educators, following a mantra credited to the Marines. We will improvise, adapt, and overcome. Thank you very much. To add a healthcare perspective, I'd like to reintroduce Dr. John Hertzer, Division Chair of the Child and Adolescent Psychiatry Program at University Hospital's Rainbow Babies and Children's.
Thank you, Jack. It's a pleasure to be here. Thank you for the opportunity. I want to start with something that I saw on a listserv this morning, as a matter of fact. A listserv that's provided by Steve Jewell, Dr. Steve Jewell down at Akron Children's. And it was titled, Well-Being of Parents and Children During the COVID-19 Pandemic, a National Survey. And it indicates, first of all, it acknowledges the widespread disruptions in daily life of U.S. parents and children. And the overall results were that since March of 2020, 27% of parents reported worsening mental health for themselves, and 14% reported worsening behavioral health for their children. Worsening mental health for parents occurred alongside worsening behavioral health for children in nearly 1 in 10 families, among whom 48% reported loss of regular childcare, 16% reported change in insurance status, and 11% reported worsening food security. There are many challenges that lie ahead of us in this unprecedented time. And while it may be too soon to talk about general trends with this pandemic, those will probably come over the next several months. We do know from previous community crises, namely 9/11, Katrina, and sadly, a series of school shootings, that some kids are more vulnerable to the emotional impact of these stressful life events and trauma. Those include kids with previous mental health history of trauma, and history of adverse childhood experiences, which we know from the ACEs studies can impact lifelong health. Some of these adverse experiences can include economic hardship, domestic violence in the household, and untreated mental health in parents. And while most children may not have clinical increased anxiety, depression, disruptive behavior, sleep disorders, substance use, I hesitate and say, well, most, because we don't know. This is unprecedented, as I mentioned earlier. We know that some will. We don't know the exact percentage that will. But it's important to identify those that are having a clinically significant impact from this pandemic. That can surface as intense, persistent emotions. It also can surface in this clinical example I bring up. Shortly after the stay-at-home order was lifted, late May, we received a couple of referrals from keen parents who, after a period of isolation, noted that their teenagers, given the opportunity to now spend more time with their friends and do more things, didn't. They brought it to their pediatrician's attention, and they received an appropriate mental health referral. I want to emphasize, parents can decrease stress in an incredibly powerful way at this time, including limiting media exposure, keeping life predictable, regular sleep, exercise, nutrition, examples of that. Give the child opportunities to ask questions. Reassure when you can, but that may not be possible, and it would be misleading in some cases. We don't know where the numbers are going to go. They seem to change every day. But the reassurance can be, in our household, these are the steps we're taking for our own health and safety, and that can be an effective way to communicate. But also teaching kids how to tolerate uncertainty, which can build resilience, is important at this time. Validating feelings, more on that in a moment. Parents need to take care of themselves. Kids follow those cues, of course. And finally, mediating measures, distancing, hand hygiene, masks in kids ages 10 and older, are not that difficult to do, first of all, and also provide a strong sense of cohesion among one another and to our community in giving the child or teen a strong sense of helping others, building empathy. I mentioned ACEs earlier. I want to flip that a little bit. This is from a study pre-COVID, October of 2019. It mentioned adverse childhood experiences, which basically is a state of toxic stress, where kids have a lot of stressful events, but in the absence of a buffering, protective, supportive adult relationship. And when I say I'm going to flip it, I'm going to talk about protective factors that were identified in this study. And it relates to schools. That's why I'm bringing it up. The title was Adverse Childhood Experiences and Protective Factors with School Engagement. And school engagement outcome was identified in 3 ways. Kids not repeating grades, kids completing their homework, and probably the most important by far, kids caring about school. The protective factors that led to these more positive results included safe neighborhood, supportive neighbors, 4 neighborhood amenities. Amenities were defined as pathways nearby, parks, libraries, recreation centers. No household smoking, at least 5 family meals per week, and most importantly, a parent who can talk to the child. The strongest protective factor is a parent who can talk about things that matter and share ideas with their child. My hope is with these very important social injustice talks, dialogues that are occurring and need to continue to occur, that these protective factors will be emphasized in measures to help our entire community. I mentioned before about youth with previous mental health treatment as being vulnerable to the impact of crises in general and this pandemic, which has made it particularly important for us to be able to have close follow-up with our established patrons, which telehealth has provided this opportunity. And it's been so vital, and which we intend to continue. One clinical example was an 8-year-old with ADHD I'd been treating for medication management. She was last seen by her therapist several months ago. Parents were reluctant to bring her back because the behavior was disruptive in the office setting. In addition, they were living in a remote area without much in the way of mental health access. So they went without the important meetings with the psychologist for some time. But telehealth came up, and suddenly the integral part of the treatment, behavioral management, was resumed. And we know through the multimodal treatment of ADHD study that that important aspect of ADHD treatment leads to better outcomes, including better parent-child interaction, and notably, it can allow lower doses of stimulant medication to be used. So that's another clinical example that telehealth, in particular in this case, has helped. I want to conclude with something that Jack had mentioned before. That pre-pandemic, there were some sobering and statistics that Jack referenced. From 2007 to 2015, emergency room visits for suicidal ideation and suicide attempts had doubled between that period of time. Also, suicide for ages 10 to 24 had increased 56% in 10 years. So we want to be able to identify youth that need mental health treatment and treat them accordingly, and possibly do so with the opportunity of telehealth moving forward. It's interesting. The teens far prefer to sit on their most comfortable couch at their house and conduct the visit. And in many cases are more open in their conversations with us because they're in a comfortable place. And they don't have to get in the car and travel for however long to go to the office visit. So I want to thank for this opportunity to be here today. And I'll transition to my colleague, Jen Reed, at Highland Springs Changes.
Hi, thank you, Dr. Hertzer. Thank you for having me and inviting me to this. So before I kind of give some info, I don't know if everybody fully knows what my program actually does. So just a quick little tidbit. Most people are familiar with inpatient level of care, 24/7, in the actual hospital. They can't leave because they're imminent risk for safety, typically actively suicidal, things like that, very acute. And then most people are familiar with one-to-one therapy. What we do fits in between those because there's a big gap in treatment. And there might be times where, people aren't imminent risk, but we don't want to put them in a lock. You always want to do least restrictive level of care at all times. I'm sorry, I saw the message. So we're that specialty in between, and it is a higher level of care than that 1 hour a week, typically. So that is what we do here, and I oversee that program in the day-to-day. And those types of services are not as accessible and commonly spread out. Northeast Ohio has only a handful of programs, so there was a definite need there when we started this facility. But in general, most people have easy access to find a one-to-one therapist, but finding something that's like IOP or PHP is a little bit harder to find. Like Dr. Hertzer said, when a lot of the shutdown and everything happened, being able to access a higher level of care was through telehealth really provided a lot of access to people that maybe lived 2 hours away that didn't have anything nearby so that they could get that access. And truly a lot of those kids were really, really struggling, and we always want to avoid them being hospitalized and it getting so bad that they are, you know, making a suicide attempt and stuff like that, because that 1 hour a week isn't meeting that need. I do, one thing like he said is there are fewer people that are getting referrals because everybody's been given the message, stay away from the ER, and a lot of people, they know when something's wrong, go to the ER, and usually what would happen is at a medical ER, they would send them to a psychiatric facility. So people aren't really knowing they can go straight to that source. So that's definitely, I think, been one of the factors, and obviously fears over COVID. But that's what I think might be some of those things, because I've had to do a lot of education with people that it's okay, you don't have to go to the ER. You can go straight to a psychiatric, pediatric facility to do that. So access to care has definitely been really amazing, how people can do that. I know from our end, like Dr. Hertzer was saying, there is something to be said for the kids where they like, a lot of them struggle with social anxiety around peers. So there's this feeling of distance that you guys might all be feeling right now with the computer because we're not in a room together, but there's something safe feeling in that, where the children are feeling like I can kind of be a little bit more open because there's a separation there, if that makes sense. That's been the feedback that I've gotten from some of the kids. A lot of what I've seen from talking with a lot of the families is that we're definitely seeing a lot of increased family dysfunction because people are home and they don't have breaks from each other. So they're all kind of getting on each other's nerves. A lot of parents are saying the kids are just fighting nonstop. I don't know what to do. I can't get them, you know, off each other, and, you know, siblings, them. So we've definitely seen that. And that is a huge stressor for a lot of people. A lot of the kids are bored because they can't go anywhere. And so all those things that they were doing to keep themselves busy that were inherently coping skills, that's been very challenging. And when we're constantly bored and we're not enriched, our mood is going to tank. So it has triggered a lot of that for people. But there have been some things that have come up when the shutdown first happened. Some of the kids actually said they were glad because they had a break from their peers. And, you know, with social media and how that works, you know, you go home and you're still interacting with people. They actually had an opportunity for a break. And a lot of parents also, because the children were home, they were able to notice more warning signs and red flags because they were home more, to be able to keep more of an eye on them. So we've been able to make sure kids are contracting for safety, as we say, where we don't have as many concerns when they're at home, because we know the parents are home more, to make sure that, you know, kids aren't having access to anything they could hurt themselves with, and all of that. So I've been giving a lot of recommendations to people that continuing to keep an eye on children, you know, keeping good communication, like Dr. Hertzer said, structure and routine. Children thrive in that. So even during the summer, I know with my child, where she's getting up at school time and then doing things through the day, when we structured fun time in there, but that seems to be really helpful too, and especially when you put siblings in separate places during those times. But getting creative with decreasing boredom, doing small co-op type things where, yeah, they're not in a huge group of kids, maybe they're in smaller groups to kind of still keep that isolated for risk factors. Self-care as caregivers, like Dr. Hertzer said, because a lot of parents are really struggling with their stress, and it's, you know, it's a trickle down in the household. And then a big thing is limiting social media, where, especially with younger children, they're not understanding what they're seeing, and they're overhearing discussions with their parents where they're scared about finances, they're scared about losing their jobs. Children, we always have to be mindful of boundaries and kind of make sure that they're hearing age-appropriate content that is coming across in a reassuring manner, where you can explain it to them. I've had to do that for my 10-year-old. Like, this is what's going on. People are getting sick. This is what we're doing. Yes, dad's going to be home, but they do need to hear it, because if they're just hearing it overheard, they're not getting full stories, and they're just hearing adults being adults and having anxiety. And it needs to come across from more of that reassuring parental way. So that's about all I have.
Great. Well, thank you each for sharing so many great insights on what is happening currently. And I think at this point, we can transition to some questions and answers. So for everyone on the call, if you have a question for the speakers, please put that in the chat box. And I think to start, I think so much of the conversations around the pandemic are focused on physical health. given COVID and the physical ailment that it is. But how do we elevate the importance of discussing mental health issues and the awareness of them? And I think so many times mental health issues come with a stigma that people are somewhat afraid or hesitant to discuss. So how do we make sure that this becomes an important conversation?
Can I take a quick stab at that, Rachel? So in our program, that's a huge objective that we strive for, is to overcome the stigma. And I think every generation is guilty of saying that the generation following them represents the end of the world. We just, what we have right now in the younger generation is a lot of courage and a lot of strength. And whether they like it or not, they have to deal with realities that we probably wish they didn't have to deal with at their age, but it's out there. It's on the internet. There's really no PG-13 or R rating in life left anymore. And the silver lining to that is, if you create an environment for these teens to talk, they're very open and willing to discuss these problems, much more so than generations before them. So we need to leverage that opportunity by creating that level of trust where they feel they can talk about it. They're a great asset, and we need to look at them that way. And sometimes we are guilty, myself, maybe more so than many, we underestimate what they know, and that's probably gone on since the beginning of time, that parents underestimate what their kids know and what they're exposed to. So give them some credit, access their courage, access their ability to talk to them honestly. And I think, as Jen said before, in age-appropriate language, but don't shy away from topics that are inescapable. We've dealt with schools where we have first grade teachers saying we should discuss suicide with their students. And they would say to us, "You're kidding yourself if you think they don't know about it."
If I can jump in on that really quick, I get a lot of parents saying, I'm worried about what my child's going to hear in a group therapy session. Maybe their child's just there for anxiety, and they're going to be going into a group where there are children who have attempted suicide, or they are frequently engaging in self-harm. And to piggyback off that, I have to say to them, they've heard about it. And at least when they're in a group setting with a master's level professional, they're not hearing who knows what, or whatever they've seen on TikTok or Instagram, or just, when young kids just talk, what kind of myths they're hearing. And when those conversations happen, the goal is always going to be why this is unhealthy and unsafe, and then to segue into coping skills and, reaching out for help. So it's a very guided discussion when that does happen. And it is really important to have those, because it does make a lot of people feel very, very uncomfortable. But when I have found with children and adults, the more information they have, the better they can make choices. And they can make smarter and healthier choices when they understand, here, this is why this is risky, this is why this is unsafe. And then when you provide them alternatives to cope or whatever it may be, they do have a tendency to move in that direction. You just have to prime them for it and give them that information.
So Jennifer, a question specifically for you, seeking a little clarification. Are all psychiatric hospitals equipped to handle walk-in patients who are looking to avoid the ER? Or is there certain distinction or language that someone should look for to identify those types of facilities?
It really depends on where they're at. So when we're looking at Northeast Ohio, there are specific ones typically, and Dr. Hertzer can probably elaborate on this more because you are involved with UH Rainbow Babies, looking for pediatric psychiatric, like that would be for children specifically, adults psychiatric. Dr. Hertzer, do you want to expand on that? I don't know if there's additional language.
At Rainbow, kids would still go through the emergency room. Sometimes if there's been a mental health evaluation that day, it becomes a more streamlined process, but we do have emergency room social workers there most of the day, and then when they are not there, our child and adolescent psychiatry fellow would evaluate kids and teens in the ER.
So Jack, to start with you for this question, at the top of so many parents' minds right now is going back to school and what that will look like, whether virtually, in person, and in hearing so much of this discussion being around school as a place for both identifying issues, but potentially also running into various issues that might cause some mental health stressors. What do services look like in the school setting based on what we're hearing and what it might be in terms of remote or fully virtual? How do we reach the students and how do we help support them?
So that's the $1,000,000 question. We are now at the end of July and we're trying to anticipate our entry points into well over 200 schools that we serve. We are developing plan A, B, C, D, E, and F, and probably have more after that. Even if schools, in a best case scenario or an ideal scenario, if it's safe enough for them to start back with in-classroom programming for their students, I think there's still going to be a limit on outside visitors, even if they're presenting programming. So I think that what we've been working on all summer is creating multiple methods to reach out to students. Obviously, we're going to be doing it online, but we're trying to make it interactive. We're trying to make it engaging and fun, where there'll be videos, there'll be ways for them to give feedback, but also self-refer and discuss the whole referral process with our professionals so that we can refer them to Changes or to UH or to other hospitals here in Cleveland. I think that the more we can do to educate the educators, because we may not be physically present in the classroom this year. The educators are really, first line providers for us, even the administrators at the schools, anything we can do to assist them. So we're kind of revamping our entire platform to serve multiple entities, not just the students, but the administrators, the teachers, public officials, the parents. We need to go after, numerous entry points to accomplish what we accomplished, I think, very efficiently over the last 15 years. We're just losing our access point this year. And I think that's going to be the case for a lot of supplemental service providers. The schools are trying, they're trying very hard. I would not want to be a school superintendent right now. I think that their challenges are big. But as I said, we will improvise, we will adapt, and we will overcome. We'll get to the students.
So how are each of you approaching the plans to identify those who might be newly suffering with mental health issues as a result of the pandemic?
John, yeah. So I want to clarify exactly what our role is in this process. So we educate teens, and now we'll be getting in the education process of parents and educators. We help them identify either themselves or a friend who might be struggling, and then we refer. We do not do counseling. What we do is we escalate it to the professionals who can help them. And again, it might be a social worker, it might be a psychologist, it might be a psychiatrist. In some cases, it's the ER. We have had students transported directly from a school after consultation with their parents, where the parents might say this is not their first attempt, take it very seriously, they need to have services right now. We're trying to streamline that. The real challenge for us is of the 3,000 referrals that we had last year, those were 3,000 in-person communications that we had with students. We're going to lose a lot of that in person this year. So we're trying to replicate that level of trust and that interaction so that we can still continue to refer students who need help to the professionals who can help them. And John, I don't know, if you can add to that.
Yeah, we tried from the outset to make it clear that our telehealth option was there for new patients as well as established patients. So we wanted to communicate that we are conducting all types of visits, whether it's a new patient or a follow-up, whether it's somebody who needs a psychiatrist or somebody who needs a psychologist. So we've emphasized that, but it does take a village, and Jack's point is well taken. When schools are in session, there's school counselors who are around kids and around friends of kids who may be having a difficult time. So That part, depending on the school this fall, may or may not be back as a access point. We'll see.
Right when the shutdown happened, with our business development team, we reached out to a lot of our contacts in local schools and basically said, hey, we're still open. Please check in with the people you know were already struggling, because they know the kids that they were working with. They know who would be more likely to be struggling, whether just what they knew about the child, or maybe they weren't logging in remotely or turning in work. You know, they were picking up on signs because they were concerned. But I even personally spoke with quite a few school counselors and said, you know, let them know we're open, let them know to check in. I'm hoping, like we will probably do when school does start up again, because now it's been summer, so they're not with the children, that we can continue to do that, or maybe it is some kind of system where, you know, they can be doing check-ins with kids to see how they're coping, and then to be able to do that. And I know one of the other things I pointed out to a lot of the school counselors and teachers is check in with the parents too, because the definite trend that we probably would see, that you can see whenever something happens, is job loss is a major stressor for suicide and suicide attempts. So maybe not with the kids, because obviously they're kids, but the adults for sure. Substance use usually increases with job loss and things like that. So if that's happening where the parent is really struggling and they lost their job, that might have a trickle down mental health, you know, impact on the children, and maybe they're needing resources, and however that may work. But you know, just basically suggesting check in with these families and see how they're doing, and remind them to go and seek out resources that could be beneficial.
So Dr. Hertzer, you mentioned using more and more telehealth. And as you see increased needs as we move forward through the pandemic, how do you begin to establish a relationship with a child or adolescent in a virtual setting?
Well, in similar ways as we have a conversation in the office. I want to get to know them, what their interests are, what their hobbies. In fact, that's how I often start an interview. And in some ways, being home gives them the opportunity to share more about themselves, their pets, their brothers and sisters, more about kind of the environment they live in at home. So in that way, I've found it at times easier to engage them.
And for those of us on the call, how can we be a source of sympathy to someone struggling with depression or those who care for them?
You know, we work with a lot of adults, and most of them, I'd say, they're very well-meaning and they want to help. They need to listen, and they need to give credence to teens who, when they say they're struggling, I think frequently first reaction, and I might very well be guilty of this, is to say, get over it, tough it out. You're a teen. Everybody goes through this. Well, we never went through a pandemic. They're going through things that other people have not experienced before. We have uncertain outcomes, as Dr. Hertzer pointed out. We got a very small data set over a very short timeline. So evaluating what the future looks like and all the future impacts is very difficult. I would say that the most important thing is take them seriously. Don't write it off. Be observant. Have a conversation with them. And this can go for parents, but it can also go for, when we're in a classroom with students, we ask them to identify a trusted adult in their life that they can talk to. It's not always their parents. It's not their parents are bad people, but maybe they're just not comfortable talking with them. Maybe their parents haven't identified that as a real problem yet. So these teens can go to other adults for help. So be attentive to that. Listen. And if a young person's coming to you and they're starting to divulge these things, take it seriously, and work with them on finding a solution. Don't write it off as teenage angst, or it's just a phase you're going through.
So as we look ahead, how can those on the call today become involved remotely or in other ways with LifeAct or even Highland Spring Changes? What are some needs that you have that the community can help you all with?
Well, I can speak to that, even though I've been doing that quite a bit, and I don't mean to box you out, John. A lot of people come to us and they're passionate about this mission. They ask how they can get involved. And the way that we can do more good is to do more. Get into more schools, get in front of more students. And I think that people can be advocates for us in a multitude of ways. The first step is getting to know us. And I would, open our door to anybody who feels that they would like to get involved with this mission. And they need to get to know what we do, how our instructors function in a classroom. And they can be an advocate at multiple levels, either with their own peer group, if it's 2 generations above. They can be a mentor to younger people. They can be a speaker. Let's say when we do community presentations. A lot of what we're doing, I would say, is not rocket science. What it is passion, and it's caring, and it's listening, and it's giving teenagers some credit for being intelligent and being courageous and coming forward. So I think that people can work with us. They can go to our website, and there's a get involved page. Our website is www.lifeact.org. And we would relish the opportunity to work with anybody. And I think that the big one is, especially Cleveland Leadership Center tends to attract people who are influential in the community. And those are the type of people who will roll their sleeves up, dig in, get involved, and make a difference. So those are the types of people that really can be of the greatest benefit to us, and they can be of the greatest benefit to kids and teens.
All right. Well, I want to again thank the 3 of you for joining us and sharing information on such an important topic. And I hope that for everyone on the call to take away today and take care of those in your networks and reach out to Jack, to Jennifer, to Dr. Hertzer as needs arise. And with that, I'm going to turn it back to Mary Ann.
Thanks so much, Rachel. And Jack and Dr. Hertzer and Jennifer, thank you so much for giving of your time to discuss this incredibly important issue. Our young people, our next generation, through all of this, are being asked to develop resiliency and innovative behaviors and adaptability in ways that are kind of predate their years and their ability to do it. So we're grateful to all of you for the work that you do every day, and all of us on this call are here to support you in that.